Discussion on management of aortic dissection. Aortic dissection is the most common aortic emergency. It is one of the three acute aortic syndromes, the other being aortic intramural hematoma and penetrating aortic ulcer. It has a grave prognosis with 20% pre-hospital and 30% in-hospital mortality. Aortic dissection is generally considered as acute when the diagnosis is made within 14 days of onset and chronic after that. An intimal and medial tear in the aorta causes blood to seep into the media, and the false lumen usually progresses along a variable extent of the aorta. Important risk factors for aortic dissection are hypertension, Marfan syndrome, and bicuspid aortic valve. Management of aortic dissection is according to its anatomical extent and duration. Pain is the most common presenting symptom, which initiates imaging studies. Computed tomography is the first-line investigation in suspected aortic dissection. Other modalities are transesophageal echocardiography and magnetic resonance imaging. Early diagnosis and management is the key to improving outcome in aortic dissection. Surgical repair, if feasible, is considered in proximal dissections. Distal dissections call for endovascular repair in the presence of malperfusion or imminent rupture. Uncomplicated distal dissections may be managed medically. Severe pain in the chest or back with migration down as dissection progresses is classical of aortic dissection. History of recent strenuous exercise or use of drugs like cocaine or amphetamines may be there. Neurological symptoms like loss of consciousness, paraparesis, or paraplegia may occur. New onset aortic regurgitation, pericardial effusion, and myocardial ischemia may occur with proximal dissection. Even though aortic dissection is classically divided into acute and chronic based on duration, another classification by Bucher and Associates divides it into 4 time domains based on data from International Registry of Aortic Dissection. From symptom onset to 24 hours, it was named hyperacute, acute between 2 to 7 days, subacute between 8 to 30 days, and chronic if it is more than 30 days. Traditional anatomical classifications are DeBakey classification and Stanford classification. In DeBakey category 1, dissection tear in ascending aorta propagates distally to include at least the aortic arch and typically the descending aorta. DeBakey category 2 is dissection only in the ascending aorta. Category 3 is dissection tear in the descending aorta propagating most often distally. It is subdivided into category 3A, in which it is confined to descending thoracic aorta, and 3B, in which the tear extends below the diaphragm. In Stanford classification, all dissections involving the ascending aorta are type A, irrespective of the site of tear. All dissections that do not involve the ascending aorta are classified as Stanford type B. Pen ABC and Dissect are other classification systems. Though several biomarkers have been evaluated in aortic dissection, only D-dimer is considered clinically feasible. It is markedly elevated in aortic dissection. Cutoff value of 500 nanograms per ml can be used to rule out aortic dissection with a negative likelihood ratio of 0.07 within the first 24 hours. In a study of 113 cases, it was found that those with younger age, thrombosed false lumen without ulcer-like projections, and shorter dissection lengths were likely to have false negative D-dimer values. Initial management of acute aortic dissection is to control blood pressure and reduce dP by dt, which is linked to the ventricular ejectile force, to reduce propagation of dissection. Blood pressure is reduced to the levels just enough for end organ perfusion. Intravenous beta blocker is the most important medical management for reducing dP by dt. Labetalol, which blocks both alpha and beta receptors, lowers blood pressure and dP by dt. Use of vasodilators without beta blockade should be avoided as they increase dP by dt. Sedation with opiates will be useful in reducing the sympathetic discharge and catecholamine levels. Mortality of type A dissection has been reported as 26% in those managed surgically and 58% in those not receiving surgery, typically because of advanced age and comorbidity. Type B dissection had mortality of 10.7% on medical management. In those 20% of type B dissection patients who underwent surgery, mortality was 31.4%. Prompt surgical treatment aims to remove the entry into the false lumen and reconstitute the true lumen with a synthetic graft with or without reimplantation of coronary arteries. Resuspension of native aortic valve is preferred to replacement for associated aortic regurgitation. Endovascular repair is considered for descending thoracic aortic dissection. Open surgical repair requires single lung ventilation, left heart bypass, profound hypothermia, and cerebrospinal fluid drainage. Hence, endovascular repair has a class 1 indication in type B dissection. For type A dissection, though endovascular repair is technically feasible in some cases, surgical repair is the standard option. In type B dissection, if malperfusion of a branch persists, then branch vessel stenting or petticoat technique with open bare metal stents can be used. Jones' criteria for the diagnosis of acute rheumatic fever was first published in 1944. Please note that the initial part of this discussion is on the original Jones criteria published in 1944. Major manifestations described in that paper were carditis, arthralgia, chorea, subcutaneous nodules, and recurrences of rheumatic fever. Minor manifestations were fever, abdominal pain, precordial pain, rashes, epistaxis, pulmonary findings, and laboratory findings. The diagnosis of rheumatic fever was considered reasonable if there was 1. Any combination of major manifestations, 2. Combination of 1 major and 2 minor manifestations, 3. Minor manifestations alone in the presence of rheumatic heart disease when other causes can be excluded. Over the years, the original Jones criteria for the diagnosis of rheumatic fever have been revised and modified several times. The 1992 update was by a special writing group headed by Dajani A.S. According to the 1992 update, the major manifestations were carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. The minor manifestations were grouped into clinical findings and laboratory findings. The clinical findings were arthralgia and fever. The laboratory findings were elevated acute phase reactants like ESR, CRP, and prolonged PR interval on ECG. In addition, supporting evidence of antecedent group A streptococcal infection were included, positive throat culture or rapid streptococcal antigen test, and elevated or rising streptococcal antibody titer. The presence of 2 major manifestations or of 1 major and 2 minor manifestations indicates a high probability of acute rheumatic fever if there is evidence of a preceding group A streptococcal infection. In 2000, another working group chaired by Patricia Ferrieri was set up by the American Heart Association to see whether further revision was required. They were of the opinion that there was no need to revise the criteria for the diagnosis of first episode of rheumatic fever. They also concluded that although echocardiography was useful in the evaluation of rheumatic heart disease, the evidence did not favor including echocardiographic findings as major or minor diagnostic criteria. AHA Committee on Rheumatic Fever, Endocarditis and Kawasaki Disease of the Council on Cardiovascular Disease in the Young has revised the criteria again in 2015. This time, echocardiography has been given a role in the diagnosis of subclinical carditis. The salient difference between the older criteria is, of course, the inclusion of echocardiography for the diagnosis of subclinical carditis. They have suggested specific echocardiographic criteria for diagnosing rheumatic valvular regurgitation of the mitral and aortic valves. In case of rheumatic mitral valve prolapse, it may be noted that only the leaflet tip will bend into the left atrium, unlike the body of the valve leaflet in classical mitral valve prolapse. Another important highlight is inclusion of monoarthritis and polyarthralgia as potential major criteria in populations with moderate to high risk of rheumatic fever. Low-grade fever has also been included in the minor criteria in such populations. For diagnosis of recurrence of rheumatic activity, even 3 minor criteria without any major criteria can also be considered. Current major manifestations are arthritis, carditis, chorea, erythema marginatum and subcutaneous nodules. Minor manifestations are fever, raised acute phase reactants, prolonged PR interval on ECG, and past history of rheumatic fever or rheumatic heart disease. Evidence of recent streptococcal infection is rather a mandatory criterion along with the above criteria. Exceptions to this rule include chorea, which may be the only manifestation of rheumatic fever, and chronic indolent carditis. Chronic rheumatic carditis has an insidious onset and slow progression. Funny current or pacemaker current is predominantly a feature of the sinoatrial node. Funny current has been designated as IF. Diastolic or phase 4 depolarization is the hallmark of pacemaker cells of the heart. IF pacemaker current was discovered by Di Francesco in 1979. It is a mixed sodium-potassium current which is inward and gets activated on hyperpolarization at voltages of -40 to -45 millivolts. Funny current initially opposes the repolarization and then stops it. After that, the funny current is responsible for the spontaneous diastolic depolarization, which ultimately leads to the automaticity of the sinus node. Since the funny current controls the rate of the sinus node activity, it determines the heart rate. IF increases on perfusion with adrenaline and thereby the slope of diastolic depolarization and the heart rate. Same effect is noted with beta-adrenergic stimulation, the effect of which is cyclic AMP mediated. In addition to the diastolic voltage, the funny current activation is also dependent on cyclic AMP and hence can be modulated by the autonomic nervous system. Parasympathetic stimulation, which has the opposite effect of beta-adrenergic stimulation, can inhibit the funny current. This would explain the sinus bradycardia associated with vagotonia. Hyperpolarization activated cyclic nucleotide channel mediates the funny current. 4 types of HCN channels, HCN 1 to 4, are known at present. HCN 4 mutations have been implicated in sinus node dysfunction. A word about funny current inhibitors. Though the pacemaker current has been described over 40 years back, it has come into attention recently due to the availability of selective IF current blockers like ivabradine, a pure sinus node inhibitor without any other hemodynamic effect. Satibradine and silobradine are 2 analogues. A similar IH current has been described in different types of neurons. Funny current and biological pacemaker. IF current has been targeted in the development of a biological pacemaker. In experimental studies, an adenoviral reconstruct including HCN2 was injected under fluoroscopic control into canine left bundle branch. During vagal stimulation, this ventricular biological pacemaker provided escape rhythm which was faster than in those without it. Discussion on catecholaminergic polymorphic ventricular tachycardia or CPVT. Catecholaminergic polymorphic ventricular tachycardia is a potentially life-threatening cardiac channelopathy with propensity for polymorphic, typically bidirectional ventricular tachycardia with exercise or emotional stress. Various genotypes of CPVT have been described ranging from CPVT1 to CPVT5 as per the online Mendelian Inheritance in Man database. The first one to be described was CPVT1 with mutation in cardiac ryanodine receptor. A review on CPVT was published by us in Heart Rhythm in 2005. The gene responsible for CPVT1 is located on chromosome 1. It is a mutation in the cardiac ryanodine receptor gene. The inheritance pattern of CPVT1 is autosomal dominant. CPVT2 is caused by mutation in the calsequestrin 2 located on chromosome 1. Autosomal recessive pattern of inheritance has been noted with CPVT2. CPVT3 has been mapped to chromosome 7. It is an early onset lethal form of CPVT. Mutations have been documented in the TCRL gene. The gene responsible for CPVT4 is located on chromosome 1 and it is the calmodulin gene CALM1. It is inherited in an autosomal dominant pattern. CPVT5 is caused by triadin gene mutations located on chromosome 6. The disorder can occur with or without associated muscle weakness. CPVT5 is also transmitted in an autosomal recessive pattern. Triadin is a protein of the calcium release complex. CPVT is initiated by conditions which increase catecholamine levels like exercise, emotional stress, or isoproterenol infusion. In its classical form, bidirectional ventricular tachycardia appears during exercise and disappears on rest in a rate-dependent fashion. The onset is mostly in childhood and most cases respond to adequate doses of beta blockers, which is the sheet anchor of therapy. Some cases which do not respond well to beta blockers may need implantation of an implantable cardioverter defibrillator. But the ICD shock itself may trigger off an electrical storm due to the associated stress. Hence, patients implanted with an ICD should also be given beta blockers to prevent such episodes. Another option for reducing the number of shocks and the consequent electrical storms is programming a longer detection interval. This will avoid shocks being given for self-limited episodes of ventricular tachycardia, but has the potential to delay treatment in case of ventricular fibrillation. Another reason proposed by proponents of longer detection interval is that the ventricular tachycardia in CPVT is initiated by triggered activity, while ventricular fibrillation has a re-entrant mechanism and may respond better to the shock. Estimated mortality of untreated cases ranges from 30 to 50% before the age of 20 to 30 years according to family studies. About 30% become symptomatic by the age of 10 and 80% by the age of 40 years according to one report. It may be noted that CPVT cannot be diagnosed by a resting ECG alone. Even though exercise testing is the most important investigation in a suspected CPVT, up to 1/5 of them may not develop ventricular ectopy during an exercise stress test. Sometimes CPVT may be misdiagnosed as long QT1 with a normal QT, which can occur in long QT1 during certain periods of time. But genetic testing is certainly useful in differentiating the two. A Pediatric and Congenital Electrophysiology Society multi-center retrospective cohort study of CPVT patients diagnosed before the age of 19 years and their first-degree relatives has been published. Genetic testing was done in 194 of the 236 subjects in the study during a follow-up period ranging from 1.4 to 5.3 years. 60% had RYR2 associated CPVT1. CPVT2 due to homozygous CASQ2 mutation was found only in 4 patients. All had history of life-threatening symptoms. Another family potentially affected with heterozygous CPVT2 included 3 subjects, of which the proband had life-threatening symptoms. Her relatives had exercise-induced ventricular bigeminy. An unusual point noted in the study was that in 1/4 of the symptomatic patients, cardiac events were precipitated by only normal wakeful activities. Discussion on cardiac pacemakers. X-ray chest PA view showing a single chamber pacemaker with lead and an aortic prosthetic valve. The pulse generator of the pacemaker can be seen below the side marker. The pacemaker lead can be seen starting from the pacemaker header where it has been screwed in. A redundant part of the lead has been coiled within the pulse generator pocket subcutaneously, as is the usual practice during pacemaker implantation. The lead can be seen coursing through the subclavian vein into the superior vena cava and to the right atrium. Distal end of the pacemaker lead can be seen to the right of the spine near the left hemidiaphragm. The fact that the lead has crossed the midline in a PA view indicates that it has crossed the tricuspid valve, which usually overlies the spine in this view. Permanent right ventricular pacing leads are often placed at the right ventricular apex, which is technically easier. Several implanters now consider a position in the right ventricular outflow tract as more physiological. While pacing the right ventricular outflow tract, a screw-in lead is needed to retain the position. Special lead stylets are available to negotiate the lead tip to the right ventricular outflow tract. Position in RVOT should be posteriorly in the septal aspect, avoiding the free wall of RVOT to achieve the objective of early entry of signal into the conduction system. Early entry of signal into the conduction system will reduce dyssynchrony, which has been considered as a downside of right ventricular apical pacing. Close scrutiny of the pacemaker lead tip can identify 2 electrodes, one at the tip and one a little proximal to that. It needs a higher resolution photograph with more penetration or ideally a fluoroscopic imaging to bring out the details of the lead tip well. This X-ray also shows a Starr-Edwards aortic mechanical prosthetic valve and sternal suture wires. The aortic position of the valve can be identified by the upward direction of the cage. In Starr-Edwards aortic processes, the cage is seen upwards with 3 struts and the sewing ring at the base. This contrasts with the mitral processes, which has 4 struts for the cage and the cage is directed downwards towards the left ventricular apex. A prominent aortic knuckle and a bulge of the right atrial contour are other findings on this chest X-ray. Cardiac pacemaker is a device meant to give regular electrical pulses to the heart when the normal pacemaker function of the heart is defective. It is also used when the pulse conduction to the ventricles is blocked, as in complete heart block. The basic electronic pacemaker consists of an electronic circuitry to generate the pulses, a battery with long storage life of several years, and leads to convey pulses to the heart. Battery and circuitry are housed together in a hermetically sealed metallic container made of biocompatible material which will not induce a foreign body reaction in the body. This part, known as the pulse generator, is usually implanted beneath the skin under local anesthesia. Modern pacemakers have highly complex circuitry capable of monitoring the body's requirement and varying the pulse rate accordingly. They are also communicating devices which can transmit the stored information to a device known as programmer kept over the surface of the skin. Programmer can interrogate the pacemaker to retrieve important information regarding pacemaker function and malfunction. Latest programmers can send the data to a server over the internet, making it feasible for the specialized physician to evaluate complex pacemaker function sitting in another country or continent. The pacemaker lead is a passive component which transmit the pulses to the heart and receives the heart signals for the pacemaker to analyze. The current day demand pacemakers will sense the heart's intrinsic activity and give pulses only when they are not present. There are pacemakers available which can pace 1, 2 or 3 chambers of the heart. They are known as single chamber, dual chamber and biventricular pacemakers respectively. X-ray chest PA view demonstrating dual chamber pacemaker with leads in situ. Tip of the atrial lead is seen in the right atrial appendage location. It is a J-shaped lead which is preformed to reach the right atrial appendage. The ventricular lead tip is seen in the region of the right ventricular apex and appears to be a screw-in lead. The dual chamber pacemaker pulse generator is seen in the left infraclavicular region. The leads are seen traversing the left subclavian into the left brachiocephalic vein to the superior vena cava and then to the right atrium and right ventricle. Dual chamber pacemakers are able to provide multiple modalities of pacing. The atrial lead senses the atrial electrogram if present and triggers the ventricular channel after the programmed atrioventricular delay. This ensures atrial health for ventricular filling and improves cardiac output. Electronic circuitry of the pacemaker can interact with electromagnetic radiation. Keep away from sources of heavy electromagnetic radiation like a powerful radio transmitter. Most other day-to-day devices can be used with certain precautions. Theft detection devices can also cause electromagnetic interference. Mobile phones can be used at a distance. The usual recommendation is to keep it on the opposite ear depending on which side the device has been implanted. Those with implanted devices are given an identification card which can be shown at airport and other similar locations where electromagnetic devices are likely to be used for security check. MRI in pacemaker patients was generally regarded as contraindicated till recently because of potential interactions between the electromagnetic field and the device. Important aspects to be considered are as follows. 1. Local tissue heating. Device leads pick up energy and transfers it to the cells, causing rise of temperature. 2. Arrhythmia induction. Abnormal heart rhythms can originate due to the interference of device function. 3. Malfunction of device software and hardware due to interference by the magnetic field. 4. Artifacts due to the presence of the device in the image, decreasing the diagnostic accuracy of magnetic resonance imaging. Newer MRI conditional devices enable better imaging on following certain preset criteria and precautions. MRI is undertaken in pacemaker patients only if the estimated benefit far exceeds the potential risks and equivalent information is not obtainable by other imaging modalities like ultrasound or computed tomography. Discussion on MRI conditional pacemakers including safety of 1.5 Tesla and 3 Tesla MRI scans. Conventionally, MRI is contraindicated in those with implanted pacemakers due to possibility of electromagnetic interference with pacemaker function. MRI conditional means that there are no known hazards when MRI is performed with pre-specified device programming, patient monitoring, and imaging protocols. MRI conditional pacemakers were first introduced in 2008. These pacemakers have less ferromagnetic material and lead design changes reduce the chance for heating. Reduction of ferromagnetic material also reduces the potential for artifacts induced by the pacemaker system in the MR images. The winding pattern of the filament of inner lead coil and geometric design of the leads have been changed to avoid resonance at the MR signal frequency to avoid heating. It may be noted that MRI conditional devices should be connected to MRI conditional leads only. Otherwise, the system will not be MRI conditional. Reed switch is replaced by a solid state Hall effect sensor which perform better within the MR console by avoiding unpredictable reed switch behavior. Reed switch behavior will vary with the strength of the magnetic field and the orientation of the reed switch in the field. Easily programmable MRI mode is available in these devices. This will prevent inappropriate pacemaker inhibition and competing rhythms. These devices have special circuitry to prevent damage to internal power supply when exposed to MRI signals. ASTM standard F2503 for making medical devices and other items for safety in the magnetic resonance environment. From the left to right, the symbols for MR safe, MR unsafe, and MR conditionally safe. Wilkoff and colleagues in a prospective randomized controlled worldwide clinical trial evaluated the safety and effectiveness of MRI conditional pacemakers in 464 patients. Patients were randomized to undergo MRI scan between 9 to 12 weeks after implantation of specially designed dual-chamber pacemaker and leads. MRI was done at 1.5 Tesla and patients were monitored for arrhythmias, symptoms and pacemaker function. Brain and lumbar MRI sequences were obtained. No complications related to MRI occurred during or after the scan. Pro-MRI Phase B study was a multi-center prospective non-randomized study to evaluate the clinical safety of the Biotronic Pro-MRI pacemaker system in patients undergoing thoracic spine and cardiac MRI. The study enrolled 245 patients with stable baseline pacing. 216 patients completed the MRI scan and 1 month follow-up. One adverse event possibly related to the implanted system and MRI procedure occurred. The serious adverse device effect-free rate was 99.6%. Real-world data of 4-year prospective follow-up in 2,629 patients with MRI conditional pacemaker system has been published by Williamson and Associates. 526 patients underwent 872 clinically indicated MRI scans, including 58 thoracic scans. No MRI-related complications occurred during or after MRI. 6 MRI-related observations were reported, which included atrial fibrillation, increase in pacing capture threshold, and chest symptoms. 171 patients underwent 2 or more scans with no cumulative increase in pacing capture threshold. MRI using 3 Tesla devices has been reported by Ning and colleagues. 20 patients with MRI conditional pacemakers underwent 23 MRI scans of different regions of the body, including brain, lumbar spine, cervical spine, and heart. Standardized protocol was developed by cardiologists, pacemaker engineers, and radiologists. No adverse events were detected and image quality was grade 1 in 16 patients. Artifacts of pulse generators and leads in cardiac MRI scan caused grade 2 quality in 4 patients without any impact on diagnostic value. Here are the first set of journal references on MRI conditional pacemakers. This discussion is on reed switch in pacemakers and implantable cardioverter defibrillators. Includes a mention on its replacement by Hall sensor in MRI conditional devices. Reed switch is used to activate the magnet mode in pacemaker or implantable cardioverter defibrillator. It is basically a collection of 2 strips of magnetic material enclosed in a glass capsule. Application of a magnetic field closes the reed switch by making contact between 2 metal strips. This changes the sensed voltage in a sensing amplifier, triggering a circuit controlling the magnet mode functional status. Reed switch can malfunction if the glass capsule is broken, remaining in same position regardless of the applied magnetic field. This situation is called sticky reed switch. The exact effect of magnet application on the various functions of pacemakers and ICDs will depend on the make of the device and the programmed parameters. But in general, the effect on pacemaker is that it stops sensing and functions in an asynchronous pacing mode. In case of ICDs, magnet application suspends all anti-tachycardia therapies without affecting the pacing mode. In most pacemakers, magnet application increases the pacing rate during the asynchronous pacing mode, but the actual rate and duration for which the higher rate is maintained will vary with each manufacturer or model. Some pacemakers can be programmed to initiate vario-threshold checking on application of a magnet. Older pacemakers have a reed switch to initiate the magnet mode, while newer devices have a Hall sensor. Hall effect sensor is the modern replacement for the reed switches in pacemakers and ICDs. It is used in MRI conditional devices. Hall effect is a generation of electrical voltage across a conductor when the magnetic field is perpendicular to the direction of current flow in the conductor. In MRI conditional devices, the Hall effect can be used to lock out the device during the scan. Limitations of reed switch. Reed switch behavior will vary with the strength of the magnetic field and the orientation of the reed switch in the field. Reed switch is replaced by a solid state Hall effect sensor which perform better within the MR console by avoiding unpredictable reed switch behavior. Discussion on right ventricular pace rhythm with retrograde P waves. ECG shows wide QRS rhythm with LBBB pattern in lead 1, AVL and V1. Axis is leftward and V6 shows negative QRS complexes indicating pacing from right ventricular apex. Pacemaker artifacts or spikes can be seen on close scrutiny in V4 to V6 just before the onset of the wide QRS complex. Andrograde P waves are dissociated from the QRS complexes. Hence, the basic rhythm was complete heart block which needed a pacemaker. Retrograde P waves marked as P prime are seen after the paced QRS complex in lead 2 rhythm strip with a reasonable retrograde conduction time. This is an interesting situation in that andrograde complete heart block coexists in the presence of fairly intact retrograde ventricular-atrial conduction. Here the retrograde P waves are negative in inferior leads, suggesting retrograde activation of the atrium. Negative P waves in V6 due to retrograde conduction during right ventricular pacing has been reported by Venkatraman K. Though usually negative P waves in V6 signifies activation starting from left atrium, that is left atrial rhythm. In single chamber pacemakers, retrograde P waves can cause reverse atrial kick as the atrial contraction occurs during ventricular systole, leading to regular cannon waves. But in dual chamber pacemaker, retrograde conduction can lead on to pacemaker mediated tachycardia. Pacemaker mediated tachycardia can be prevented by programming the post-ventricular atrial refractory period or PVARP beyond the time of occurrence of the retrograde P wave. Pacemaker mediated tachycardia or endless loop tachycardia occurs because the retrograde P wave is detected by the atrial circuit of the pacemaker and triggers a ventricular pacing after the programmed AV delay. This ventricular pace beat can again be conducted back into the atrium, forming a circus phenomenon. Programming PVARP makes the atrial circuit refractory when the retrograde P wave arrives and prevents triggering of ventricular pacing and hence the endless loop tachycardia. Mitsui and associates were the first to describe pacemaker syndrome in 1969 as a symptom complex associated with right ventricular pacing. In general, pacemaker syndrome is due to a loss of AV synchrony and it is relieved by AV sequential pacing. But of late, the role of VV synchrony has also been highlighted so that efforts to minimize right ventricular pacing has been promoted. Patients with pacemaker syndrome may present with exertional dyspnea, hypotension, near syncope or even syncope. Syncope occurs in the setting of a drop of systolic blood pressure more than 20 millimeters of mercury at the onset of ventricular pacing. Easy fatigability, sensation of fullness and pulsation in the head and neck are also features of the pacemaker syndrome. When an intact VA conduction is present, the pacemaker syndrome may be more severe due to the reverse atrial kick associated with every cardiac cycle. Venous pressure elevation as a result of atrial contraction against a closed AV valve causes reflex peripheral vasodilatation and hypotension by stimulating the vagal efferents. The reported incidence of pacemaker syndrome varies widely. In those trials in which a dual-chamber pacemaker was implanted and programmed to single-chamber mode for the study purpose, the changeover rates to dual-chamber mode for suspected pacemaker syndrome was high. But in those trials in which a surgical revision was required for a mode change, the reported incidence was low. This may indicate a lower threshold for the diagnosis of pacemaker syndrome when surgical revision is not required. Discussion on the role of positron emission tomography in cardiology. Positron emission tomography imaging is useful in assessment of myocardial perfusion and viability, atherosclerotic plaque activity, as well as cardiac innervation in heart failure. PET is also useful in prosthetic valve endocarditis, endocarditis associated with cardiac implantable electronic devices, infiltrative cardiomyopathy, aortic stenosis, and cardio-oncology. PET imaging has superior diagnostic accuracy compared to single photon emission computed tomography. It has improved spatial and temporal resolution and can measure regional blood flow and has less radiation. In PET, high energy gamma rays of 511 kilo electron volts are emitted at 180 degrees during annihilation of positron and electron. This compares with 140 kilo electron volt for technetium. The high energy gamma rays are absorbed by the detectors, giving better resolution images. The radiation exposure of PET was reported as 6 millisieverts versus 11.6 millisieverts for SPECT. A meta-analysis compared rubidium-82 PET with SPECT regarding the detection of obstructive CAD. 15 studies on PET and 8 studies on SPECT having 1,344 and 1,755 patients respectively were included. They concluded that rubidium-82 PET is accurate for the detection of obstructive coronary artery disease and is superior to SPECT. The extent and severity of ischemia and scar noted on PET stress myocardial perfusion imaging has been shown to be a powerful and incremental risk predictor for cardiac death and all-cause mortality compared to traditional coronary risk factors. Thus, PET is useful in risk stratification as well. Another role of PET is in the identification of hibernating myocardium, which will benefit from revascularization. Preserved metabolic activity in the myocardium noted on PET has been considered as the gold standard for myocardial viability. 61 patients with regional valve motion abnormality underwent PET before revascularization. 43 patients who had successful revascularization were included in a study. Patients underwent rest stress N13 ammonia perfusion scans and FDG scans at rest in a fasting state. FDG PET had best predictive value for improvement in valve motion abnormality after revascularization. N13 ammonia PET was useful in predicting non-reversible myocardial scarring when it shows severe hypoperfusion at rest or hypoperfusion without stress-induced ischemia. In prosthetic valve endocarditis, acoustic shadowing by the prosthetic valve makes detection of small vegetations in endocarditis difficult. In a study of 72 patients with suspected prosthetic valve endocarditis, 36 had abnormal FDG uptake around the site of the prosthetic valve. This increased the sensitivity of modified Duke criteria at admission from 70% to 97%. FDG is able to identify inflammatory and infectious processes by measuring the metabolic tissue activity. Authors suggested adding FDG uptake around the prosthetic valve as major criterion for the diagnosis of prosthetic valve endocarditis. Similar role for PET has been established in CIED-associated infections. In a study, 32 of the 42 patients with suspected CIED infection had positive PET-CT. 24 of them underwent extraction with excellent correlation. 6 patients were treated as superficial infection and had clinical resolution. In one patient, positive PET-CT with negative leukocyte scan was considered as false positive due to Dacron pouch. Remaining 10 patients with negative PET-CT were treated with antibiotics and none had relapsed over a mean follow-up period of 12.9 months. PET is also useful in the evaluation of cardiac sarcoidosis. In a study, 118 patients were evaluated with FDG PET to assess inflammation and rubidium-82 PET to assess perfusion defects following a high-fat, low-carbohydrate diet to suppress normal myocardial glucose uptake. The presence of focal perfusion defect and FDG uptake on PET identified patients at higher risk of death or ventricular tachycardia in the study. Pittsburgh B compound PET in patients with light chain cardiac amyloidosis has shown that it indicates the degree of amyloid deposit and is an independent predictor of clinical outcome. Fluorine-18 sodium fluoride PET may be useful for disease monitoring and localizing amyloid deposition in transthyretin amyloidosis. FDG PET-CT can measure disease activity and progression in aortic stenosis. PET can measure valvular calcification and inflammation in aortic stenosis. These are assessed using fluorine-18 sodium fluoride and FDG PET. Correlation with disease severity was strongest for fluorine-18 sodium fluoride PET. PET has application in cardio-oncology as well. Presence of uptake in the right ventricular wall in PET-CT after therapy with anthracycline or trastuzumab in breast cancer patients were associated with cardiotoxicity. Thus, oncologic FDG PET-CT scans provide information on tumor response and therapy-induced cardiotoxicity. Discussion on Neoatherosclerosis and In-stent Restenosis. Neointimal proliferation can occur within a coronary stent. Chronic inflammation within the neointima with infiltration of macrophages leads to neoatherosclerosis and result in in-stent restenosis. Disruption of neoatheroma can cause acute thrombotic occlusion. Hence, neoatherosclerosis is a complication of percutaneous coronary intervention and can present with recurrence of angina or acute coronary syndrome. Occurrence of neoatherosclerosis is earlier in drug-eluting stents than in bare metal stents and has greater prevalence. Late stent thrombosis due to rupture of the plaques with thin fibrous cap is associated with high mortality. Thus, in-stent neoatherosclerosis is an important contributing factor to late vascular complications of very late stent thrombosis and late in-stent thrombosis. Neoatherosclerosis is characterized by plenty of lipid-laden foamy macrophages with or without calcification and a necrotic core in the neointima. While native coronary atherosclerosis takes decades to develop, neoatherosclerosis may develop in months to years after stent placement. Lesions of neoatherosclerosis can be detected by optical coherence tomography. A study of 406 neoatherosclerotic lesions from 299 autopsies in the CV Path stent registry included 197 bare metal stents and 209 drug-eluting stents. 103 were sirolimus eluting stents and 106 paclitaxel eluting stents. Neoatherosclerosis lesions were noted in 31% of the drug-eluting stent lesions and 16% of bare metal stent lesions. Median stent duration was shorter in case of drug-eluting stents. Unstable lesions with thin cap fibroatheromas or plaque rupture were more frequent in drug-eluting stents. Mean implant duration was 1.5 years in drug-eluting stents and 6.1 years in bare metal stents. Younger age, longer implant durations, drug-eluting stents, and underlying unstable plaques were the independent determinants of neoatherosclerosis identified by multiple logistic regression. Reformation of an endothelial cover is delayed after drug-eluting stent implantation. Hence, the neointima is more prone to become lipid-laden and develop neoatherosclerosis, increasing plaque vulnerability. Near-infrared spectroscopy with intravascular ultrasound was used along with optical coherence tomography to characterize neoatherosclerotic lesions in 65 consecutive patients with symptomatic in-stent restenosis in a study. 51 had drug-eluting stents and 14 bare metal stents. Neoatherosclerosis was confirmed by optical coherence tomography in 40 stents, of which 68% were drug-eluting stents. Thin cap atheroma was noted in 47% with drug-eluting stents and 7% with bare metal stents. Near-infrared spectroscopy showed that total lipid core burden index and density of lipid core burden index were higher in drug-eluting stents compared to bare metal stents. Neoatherosclerosis was classified into thin cap type 1, thick cap type 2 and peristrut neoatherosclerosis type 3. Type 1 thin cap neoatheroma was more common in drug-eluting stents and in areas of stented segments without significant in-stent restenosis. It was associated with more of periprocedural myocardial infarction. In a study of 313 in-stent restenosis between 2009 and 2017 in patients undergoing OCT-guided percutaneous coronary intervention, neoatherosclerosis was defined as a lipid neointima or a calcified neointima. eGFR, time from PCI to in-stent restenosis, and drug-eluting stent ISR were independent predictors for neoatherosclerosis in this study. Intravascular lithotripsy has been used to treat recurrent restenosis due to severe calcific neoatherosclerosis in another report. A study of 185 patients with ISR suggested that low-density lipoprotein cholesterol levels may be related to the formation and progression of early neoatherosclerosis. They suggested that poor control of LDL cholesterol may be a risk factor for occurrence of early neoatherosclerosis following drug-eluting stent implantation. Intensive therapy with rosuvastatin plus eicosapentaenoic acid was used in a study evaluating in-stent neoatherosclerosis with OCT. In that study of 42 patients, intensive therapy prevented atherosclerotic progression more effectively in native coronary plaques in patients with neoatherosclerosis. Discussion on health effects of partial hydrogenation of vegetable oils. Partially hydrogenated vegetable oils contain trans fatty acids, which are different from the natural fatty acids in vegetable oils and animal fat. Fatty acids in partially hydrogenated vegetable oils are 14 cis and trans isomers of octadecanoic and octadecadenoic acids that are formed during hydrogenation. Trans fatty acids cause inflammation and calcification of arterial walls. They also inhibit cyclooxygenase needed for conversion of arachidonic acid to prostacyclin, a compound beneficial for the vascular tree. There are reformulations of hydrogenated fat containing the essential fatty acid linoleic acid, which gets converted to arachidonic acid. When trans fat content goes up and linoleic acid content goes down, mortality rate rises as per epidemiological data. Hydrogenation of vegetable oils were innovated for increasing the shelf life. It is common knowledge that vegetable oils can become rancid on storage. This is tided over by hydrogenation and hence the shelf life increases. But trans fatty acids seen in partially hydrogenated vegetable oils have been shown to damage pancreatic beta cells and increase insulin resistance in animal studies. Trans fatty acids cannot be fully eliminated from diet as they are also present in meat and dairy products of ruminant animals. Industrial trans fatty acids promote inflammation, whereas cis unsaturated fatty acids are protective against inflammation. Industrial fatty acids also promote fat storage in the liver compared with cis unsaturated fatty acids and saturated fatty acids. In vitro studies have shown that industrial trans fatty acids but not cis unsaturated fatty acids or saturated fatty acids stimulate the cholesterol synthesis pathway by activating sterol regulatory element binding protein 2 mediated gene regulation. A meta-analysis checked effects of replacement of partially hydrogenated vegetable oils with alternative fats and oils on coronary heart disease. 1% replacement of trans fatty acids with saturated fatty acid, monounsaturated fatty acids or polyunsaturated fatty acids decreased total cholesterol by high density lipoprotein cholesterol ratio by 0.31, 0.54 and 0.67 respectively. The replacement with animal fats and vegetable oils could reduce the estimated risk by 65 to 80% and 50% respectively. In another systematic review and meta-analysis, total trans fat intake was associated with all-cause mortality, coronary heart disease mortality and total coronary heart disease, but not with ischemic stroke or type 2 diabetes mellitus. This was contributed mainly by industrial but not ruminant trans fat, as industrial trans fat was associated with coronary heart disease mortality and coronary heart disease. Ruminant trans palmitoic acid was inversely associated with type 2 diabetes mellitus. Industrial trans fat is produced by partial hydrogenation of vegetable oils in the presence of metal catalyst, vacuum and high heat. Ruminant animals biohydrogenate unsaturated fatty acids via bacterial enzymes, but ruminant derived trans fat consumption is relatively low in most populations. Another review mentioned that 2% absolute increase in energy intake from trans fat has been associated with 23% increase in cardiovascular risk. They can increase blood levels of low density lipoprotein cholesterol.